would like to welcome everyone to this Wednesday night session on dermatology, interesting dermatopathological cases. And I put on my screen the flyer again on the 36th ISDP symposium. And if you guys could attend this meeting, please go. It will be a tremendous learning opportunity. So this is an utmost pleasure for me to have Dr. Vyacheslav Tonkovic Capin on the series. And I'm especially happy that he's on this program because this is foremost of an international program of dermatopathology. And I like to invite people who are from different countries or who I know for a long time. And Dr. Tonkovic Capin is from Croatia, which is one of the most beautiful places on planet Earth. If you haven't been there, and I really encourage you to go there because it is extremely rich historically, and it is also has a fantastic scenic views. You have to check out the Adriatic Sea and also towns like Dubrovnik, Split. These are absolutely fantastic. I hope that Visha will put a couple of images into his presentation. Yes. And on the other hand, Dr. Tonkovic Capin, or Visha that we call him, is an extremely established dermatopathologist that I know from his dermatopathology fellowship at the University of Texas Southwestern. Now, currently, he is a staff dermatopathologist at Kansas City Veterans Administration Medical Center, Division of Pathology and Laboratory Medicine, Kansas City. And he's also in a private general dermatologist, and he's also doing an active dermatology practice within the Premier Specialty Network. And it is also important to know about Visha that he's a very kind of to the point person, and he has a lot of great ideas about a lot of other things. I don't know how much you will put into this presentation about wise things about life, how to eat, what to eat, and how it works. But I learned not just dermatopathology and dermatology from him, but also maybe even kind of more important things. How to arrange a healthy life around us, and he's a great teacher of that. So I would actually myself would love to have a presentation, all his experiences, because he's doing a very special diet. So with that, Visha, thank you so much again for agreeing and coming on, and we are looking extremely excited to your presentation.
Thank you, Laszlo, for your kind words. Now I'm going to sound like some nutritionist freak or something. But thank you again. And so I prepared few cases that I encountered in the past few years since I graduated from Clay Cockrell's Dermatopathology Fellowship. So first case would be this case, and it's a gentleman in his 70s. And this is the case from my good friend Michelle Jackson from San Diego. So this patient presented to another dermatologist with this lesion on the nose. So if someone can just type their differentials so that Laszlo can tell me what kind of differentials we are getting from you guys. Just type anything what you think this could be, without knowing anything else about the patient. Okay, time's up. So what do we have?
We have basal cell carcinoma.
Good, excellent. What else?
MEC, microcystic adnexal cell carcinoma.
Good, excellent. Next. It has a little bit purplish color too, as you can see here.
Dr. Penisharo says it's an angiosarcoma.
He's good too. That's also great differential. So for me, I mean, if the patient came to my clinic first time, I'll just say it looks like scratch or something. I don't know, maybe some angioma here. It could be basal cell carcinoma, but I definitely would do biopsy. And he has also probably some AK here, so he has some damage there. So, and his dermatologist, who wasn't Michelle Jackson, some other dermatologist, did actually not dermatologist, but physician extender did a biopsy. So it wasn't done by a physician, but it was read by his or her derm as a sebaceous hyperplasia. So you need to know that on West Coast, I think at least 50% of general dermatologists are reading their own biopsies. So that's kind of tradition there. And we have good training in dermatopathology. Almost like a third of our training as a dermatologist is also to read biopsies. So they do that there. So the patient, so his derm just read as sebaceous hyperplasia. Patient comes back again, and my friend Michelle looks at this thing. So what would be your differential at this point? I'll wait 10 seconds. So it looks like purplish plaque here. The entire left ala is involved.
Merkel cell carcinoma.
Almost like. Okay, good.
What was the timing between
Anyone else?
Visha? Do you know how many weeks?
Well, I don't have all details, but apparently just patient came back. He doesn't look much older on this picture. Honestly, I don't know.
Lymphoma, B-cell lymphoma, Kaposi sarcoma.
Very great differentials. I had actually a similar case on the lip like this, and turned out to be B-cell lymphoma. One was actually even a renal cell carcinoma, looking similar to this. So Michelle got this biopsy to look at. So it looks like punch biopsy of this recurrent thing, and look like there's some spaces in the superficial, like epidermis is relatively a little bit thicker, but nothing much in it. And then there's some spaces in the superficial dermis with extravasated red blood cells, and also looking like little spaces and kind of pretty cellular dermis there. So there's a very cellular dermis and some spaces with extravasated red blood cells. So what would be your diagnosis now, guys? Any differential? I'll wait 10 seconds.
Kaposi.
Good.
KS.
Excellent. What else? Okay, so we'll move on. If you get more differentials, Laszlo just shoots, just interrupt me. So we have a close-up of it. If anyone wants to put more differential, go ahead. So these cells that we see in the dermis that are a little bit more kind of busy dermis with this dissecting kind of vascular spaces and extravasated red blood cells kind of involves the entire dermis. And these cells look, well, some are darker, some are a little pale, they look a little bit different shapes. There's larger cells with larger nucleoli, and kind of goes from the top to bottom, left to right. So it's pretty kind of involving the entire biopsy. A closer look, again, the same thing, that these cells are a little bit darker. This could be even mitosis here. They look pleomorphic, meaning they look different from each other, and they're darker or hyperchromatic. So look at this cell compared to this cell or this cell, and they look different from each other. And also, again, extravasated red blood cells. So it's kind of something that permeates the entire dermis. Any differential at this point? Any additional differential? Okay, it seems I can't see what you type, so Laszlo needs to read.
There is nothing else. Nothing else.
Okay, good. So again, these cells close up, but we can see also that there are a bunch of eosinophils here. Can you see my cursor here? So
Yep.
there are a bunch of eosinophils. Some are degranulated. And these cells, again, endothelial cells looks like blood vessels, are hyperchromatic, and bunch of eosinophils. Any additional differential at this point when we see there are a bunch of eosinophils here?
It is angiolymphoid hyperplasia with eosinophilia.
Excellent. So many great dermatopathologists would think about that and maybe even diagnose it as that. So, and we have also a close-up again, pleomorphic cells, large cells, and also some eosinophils. We'll see more eosinophils here. It's a little bit sharper image. Again, you can see those eosinophils here. And here's one nice classical bilobe nucleus, this granules. So a bunch of eosinophils and pleomorphic cells. So what this could be? So we have a little informal group of ex-Cockrell's fellows and associates, and we kind of share these cases that look a little bit unusual among us, and we text to each other and email to each other a look, and we just shoot short differential what this could be. So we were very worried about angiosarcoma in this case, and we sent to Laszlo, Michel sent it to Laszlo for formal consultation, and he issued a report calling it angiosarcoma. So the patient was referred to ENT in San Diego, who excised this lesion and sent specimen to an institution on the West Coast. And two derm paths in that institution called it angiolymphoid hyperplasia with eosinophilia, and they call it with clear margins. And in addition, they adamantly refuted the original Laszlo's diagnosis of angiosarcoma. So in this case, started a little bit unpleasant period because the patient had surgery of the nose and cosmetically sensitive area for something that is benign, for this angiolymphoid hyperplasia. However, our group was not convinced that this is angiolymphoid hyperplasia, and we totally ignored this bunch of eosinophils and dermis. We just deemed them to be of no any significance in this case, and you'll see why we think that there was no any significance. I'll address this a little bit later. So let's see this. I just looked about this angiolymphoid hyperplasia, and indeed it can look like angiosarcoma. And so this is the case of 29-year-old woman who had these papules behind her ear. And these papules, compared to our gentleman, are brownish red. So classic presentation of angiolymphoid hyperplasia are these red, brownish papules around ears, and it can be on genitalia and some other places too. I had one patient had it on elbows. But it's usually in younger people, like in 30s. I think the median age is 32. So when you compare to our patient who had this bruise-like, bloody-looking purple nodule, compared to this, doesn't look like much of angiolymphoid hyperplasia. It doesn't look like classic presentation. But when we look at this case in this report, and these cells indeed look darker, hyperchromatic, and pleomorphic, or they look different from each other. And kind of they have these blood vessels similar like in our case. However, also in this case, this neoplasm kind of does not involve the entire dermis. I mean, it's just like more like well circumscribed. And what happened to our patients? So after 9 months after that excision of angiolymphoid hyperplasia with clear margins for those people on West Coast, the lesion reoccurred. And so again, it was excised by ENT and again sent to the same institution on the West Coast that subsequently changed its diagnosis to angiosarcoma. So they came back to the original Laszlo's diagnosis of angiosarcoma and to our original suspicion. And patient is currently undergoing X-ray treatment of the area. So question was why there were so many eosinophils. So probably these guys, those two dermatopathologists at that institution on the West Coast, were kind of, I think, a little fooled by this eosinophils. And we totally ignore them. And the reason being is simple, is that any trauma to muscle causes stromal eosinophilia. So probably that the original biopsy, the one that was done by physician extender and that was read by his dermatologist as sebaceous hyperplasia, resulted in underlying muscle injury that caused this stromal eosinophilia. Just to prove you that, there is a report from Cell in 2013. And this little paper comes from UCSF. It demonstrates in this paper that muscle damage results in rapid recruitment of eosinophils, which secrete interleukin-4 to activate the regenerative actions of muscle. So that's in this case. But we knew this in our fellowship. We had to rotate through the oral pathology department of Baylor College of Dentistry, and they frequently see there so-called TUGSE, which is TUGSE, which is traumative ulcerative granuloma with stromal eosinophilia of tongue. So injury to tongue causes non-healing ulcer with lots of eosinophils. And those guys there, they kind of taught us, and basically they told us, any injury to skeletal muscle causes lots of eosinophils in the tissue. So the key problem here was that those dermpaths from West Coast, they didn't take into account the clinical presentation. So this was older gentleman. It was on the nose, and it was purple looking and kind of ill-defined. You could see all kind of bruise coming on the sides of it. And they didn't take the context of the lesion into account, that this lesion has been previously biopsied, so probably had this skeletal muscle injury from the original biopsy. And they obviously disregarded then this really significant atypia of these endothelial cells. It's very striking atypia. So for any diagnosis, I hate to put in my reports final diagnosis. I don't think that my microscopic diagnosis is final diagnosis. The only final diagnosis is clinical diagnosis plus pathologic diagnosis. So I like to put in my reports pathologic diagnosis. And I leave to clinician to come up to real diagnosis, because I didn't touch the patient. I didn't see the patient. At the best, I see sometimes more description of the lesion. Sometimes you see photographs. My VA is really good. I take photos, but sometimes you just rule out atypia, and that's it. So the final diagnosis is clinical diagnosis and pathological diagnosis taken all together. They totally disregarded this thing. This is my hometown of Split in Croatia. It started around the Diocletian Palace here. It's along the coastline on the Adriatic Sea. And this Diocletian Palace, this guy, Diocletian, in 2nd century, started his summer house there, basically summer palace there. And the city grew around it. And now there are a bunch of Roman ruins in the city, but it's all inhabited. It's all kind of merged together with a residential area. So it's very interesting to see. In many other places you go and you see those Roman ruins or ancient Greece ruins that are totally separate from the cities. But this is total living ruin, kind of. Any question about the previous case? Yes?
Yeah, I mean, I just have one comment to make that, that I just want to make it clear that it wasn't my suggestion that to present this case. I mean, I don't mind you presented it. It was a fantastic case, but, I just want to kind of make it clear that maybe this time I got the diagnosis, but, it wasn't like that, okay, well, I was telling you that, hey, Michelle, could you show this case or anything like that?
Laszlo, you're too humble, okay? So, but this case is a super case, illustrative case, how importance of clinical pathological correlation is super important to come to the final diagnosis. And honestly, this is one of the best cases I've seen in the past 3 years, so why not to show it? And indeed, Laszlo didn't even say he was surprised when we saw it. And he provided me some pictures just day before, because I didn't have the last picture of the recurrence. So next case. So this case is obviously older, a person from Kansas City, VA, has bruise-like plaque that stops at the midline on his left abdomen. This is the abdomen here. Here's the ribs up there. And it looks like kind of edematous bruise-like plaques. So any differential? I'll wait 10 seconds. Just go ahead.
Kaposi sarcoma.
Okay. So if the,
Yeah.
mhm.
Herpes. Herpes zoster.
Herpes, yeah, great. Yeah, excellent. What else? Okay, good. I'll move on, and if you come up with more, you let me know.
Abuse. Angiosarcoma.
Excellent. Yeah, angiosarcoma, herpes zoster, wonderful. And I've seen cases like this, edematous dermis and systemic amyloidosis as well. So this could be too. So this is a older gentleman, 83-year-old male. This is copy from a VA system from CPRS. So if any of you use a VA system, they're familiar with this. I just copy and paste this on my PowerPoint. So physical examinations, indurated erythematous and purpuric plaques on left abdomen, wrapping around to left back. So their impression was angiosarcoma, very reasonable, versus amyloidosis, very reasonable, versus post-zoster dermatitis. So when I see post-zoster dermatitis, I assume that patient had zoster in that area. So they did punch biopsy of this lesion, and it showed some kind of spaces in the superficial dermis and some kind of blue cells around here. And in these spaces, there are some kind of floating cells. Any differential at this point?
Angiosarcoma.
Good. So again, we have those spaces but they're a little bit wider and larger. So we have a little bit close up again, something's floating here in this space here, which is that. So probably this is that edema that you see, those dilated blood vessels, but something's floating in it. And then we have some collections, like round collections of clear cells with kind of a tiny blue nucleus.
Carcinomatosis from the Topaniciaro. Mucinous carcinoma from Jessica.
Excellent, excellent. So we're coming close up again, those cells floating. So whenever you see something floating, you think about metastasis in the spaces. This is from another punch biopsy there. Again, the same thing floating there in the vascular space. And now again, close up of this thing looks like clear cells with the dark nuclei and kind of vascular spaces here. Any differential now? Or diagnosis? Okay, I'll move on. So it's another close-up of these cells.
Carcinoma.
What kind of carcinoma?
Renal cell carcinoma.
Renal cell. Yeah, that's excellent. Yeah, renal cell carcinoma. Yep. So this almost looks like glomerular, kind of like a collection of these uh, uh, renal glomerular with blood cells and vessels there. So we did, we thought it's a renal cell carcinoma. So we did a renal cell carcinoma antigen stain immunohistochemistry. And is it positive or it's negative? So I like these questions. That's what Laszlo would always ask us. Is this positive or it's negative? Any answers? Yes or no? Okay, it's simple. I think it's yes, but it's just few cells here. But some were totally negative. So if you got a little shaved biopsy, we could have missed that this thing is really positive for RCC. It's kind of membranous stain there, but it's kind of barely positive. It's very, it's not totally convincing, but it's positive. And we have this one here. So I would call it renal cell carcinoma with this. So, but somehow it's kind of like milk toast. It's not always strong. So we did PAX2 stain too that showed that these cells are really positive, and I'll talk a little bit later about this PAX2. So really positive, but it also stained eccrine glands. So it's not totally specific. It's very sensitive, but it's not specific. Kind of stains everything, kind of. So we did another stain. So this is this PAX2 again. Stains this neoplastic cells, but also eccrine glands. So not specific. So we did the CA9. So you can, I'll talk about this stain a little bit later. Again, stained lots of these cells, but not everything again. And it didn't stain this eccrine glands. So this one is quite specific, but it's not as sensitive as PAX2. So again, didn't stain this eccrine glands, but stained neoplastic cells. And not all of them again. So this is metastatic renal cell carcinoma. So RCC is antibody to proximal tubule antigen. It's very specific, but only positive in about 2/3 of mets. So in 1/3, you may not get positivity. PAX2 comes from paired box2 gene, so hence its name. It is a transcription factor necessary for kidney development. It's positive in about 80% of mets. It's nuclear stain. And then we have CA9 or carbonic anhydrase 9. It prevents cell death due to hypoxia. So it's not found on normal kidney cells. So this one should not be found in normal kidney cells. Any questions about the case? Good. So this was unusual presentation of the renal cell carcinoma. So you do biopsies when you're not sure. That's simple. And you do a panel of stains because they're not always super sensitive or specific. So this is city of Dubrovnik. It's southernmost city in Croatia. It used to be independent republic up until maybe 200 years ago. And it was the first, actually second state to recognize the independence of United States after France recognized it. So it's a little connection to the United States. It was big. This city-state was big competitor to Venice. Have another case from my residency actually in Milwaukee at Medical College of Wisconsin. So this patient showed up. Actually, didn't show up, but it was a consult from floor. It told us, oh, we have the patient with this rash on his face and other areas. So it looks like inflammatory papules, maybe pustule on the face. So any differential? Again, at my training program, Medical College of Wisconsin, they taught us to come up with differential without even knowing anything about the patient, just to see the patient, and that's it. You come up with differential. So which actually I didn't like during my residency, but actually it really helped me afterwards because you want to be fast in your clinic.
Lymphomatid papulosis.
What did we get?
Pseudolymphoma so far and lymphomatid papulosis.
Okay, excellent. So look, a different look here. We have these papules here, inflamed papules. Some look like, well, maybe pustular and kind of umbilication. And any differential now? Any changes?
Molluscum contagiosum.
Excellent.
Coxsackie, I think. No, sorry. Coccidiomycosis, sorry, the fungal infection.
Fungal.
Plasmosis.
So this is again this pustule and stuff. You know, you could even looking and during your test, if you don't know anything about it, you could see, oh, it's rosacea or some acneiform lesion. But then the patient has also these lesions on his palms, so it's probably not rosacea. It's not probably, no, it's not. It's not any folliculitis or any acneiform eruption. So it's something disseminating in this patient causing pustules. So
Crypto.
just a little bit history now. Go ahead. So a little bit of history. So this gentleman was immunosuppressed. He had kidney transplant. So he was admitted with fever and headache to the fore, and scattered pustules on face, trunk, and extremities for about several days. And so we looked at the laboratory data. Actually, we did this KOH and zinc, and it was negative. We did CBC with differential, showed, I mean, it was already done. So we looked he had leukocytosis. Chest CT showed several pulmonary nodules. Brain MRI showed multiple small foci of enhancement. Blood and urine cultures were negative, so nothing in blood or culture or urine. CSF was clear with elevated white blood cells, RBCs, and protein. So what's your differential now when you have this information? Anyone?
No new diagnosis, but you know, cryptococcosis, Luis,
Excellent.
came up.
Yeah. So we did biopsy, obviously, and it showed kind of relatively thicker epidermis, a little bit of parakeratosis, and this epidermal kind of hyperplasia here. The cells were not, it looks almost like cancer, you know, but the cells were not atypical. So this is pseudoepitheliomatous hyperplasia with a bunch of neutrophils. So lots of abscesses there. So we have this pseudoepitheliomatous hyperplasia. So whenever you see this, you think about deep fungal or some infection. Leishmaniasis can mimic SCCs or any this iododerma and stuff like that, like halogenoderma. And on the H&E, you could see these kind of cells, you know, like looks like yeast cells, like large organisms there. Here, even without this PAS stain. So you immediately start thinking, yeah, this must be deep fungal. But what kind? So on PAS, you could see broad-based budding. So when you see broad-based budding and this yeast forms, what is your differential at this point?
Blasto.
Excellent. Yeah, this was disseminated blastomycosis. So the patient was started immediately on IV amphotericin B, and his immunosuppressive regimen was adjusted, decreased, obviously. And after 2 weeks, he survived, luckily enough, but he was discharged on fluconazole PO for life. So whenever you get this in the brain, you got at that time you need to have this fluconazole for life. I think it's still true now. So in conclusion, the skin biopsy was the most crucial and likely life-saving diagnostic test. So they didn't know what's going on with this guy. KOH preparation is usually diagnostic. However, in this case, it was negative. And I know why, because it was a bunch of us first and second year residents didn't know what we were looking at. And we were expecting some viral things, so we were looking for viral. We kind of wired our brains for viral things, and we didn't look for any yeasts. So probably it was there, but we didn't see it. Any questions? Okay, so this is Golden Beach in Croatia. It's an island Brač, and it is the most beautiful beach in Europe, and I think one of the most beautiful beaches in the world. And it's compared to many beaches, it's not sand, it's just fine kind of pebble beach, very, very fine stone beach. So it's much nicer when you lay on it. It's not invasive, doesn't get into your skin folds, this sand. So it's much nicer to lay on it and enjoy the weather and the sea. interesting thing about this beach is that this tip kind of sways one way or another way depending on currents and wind. And so at this point, it was just straight up there. So you should, if you ever get chance to go there, you should go there. It's a really cool place. So I have another patient here who has older gentleman who has on the back of his left ear some kind of purple, kind of pinkish yellowish papule. So what is your differential at this point? Just go ahead, just do something. Give some differential.
SCC.
Excellent. What else? Yeah, we always think about non-melanoma skin cancers. Anything else?
Xanthoma.
Excellent. All excellent diagnosis. But you know, obviously we would biopsy this.
Merkab.
Unless you, yeah. So this was 67-year-old white male with lesion on posterior ear. So this is the biopsy. And who knows, his derm path has diagnosis at this point. So what is the diagnosis? This is very characteristic. This kind of orangish red parakeratosis. And this kind of verrucous look, this papillomatosis and this orange-red parakeratosis. Anyone?
Yes, verruciform xanthoma.
Excellent. Yeah, that's it.
Yep.
And you can see that when you see this and during your boards and stuff, when you see this, this is it. There's nothing else. And you can see also if you want to play with it, if you have extra time during your boards, you can look. There are foamy cells in dermal papilla there. And here too. Here are those foamy cells. So that's verruciform xanthoma. So it shows up on oral and other mucosal surfaces, but can be anywhere. And this is the catch with the derm board, and they'll give you the slide, and then you need to come. This patient can have what of the following, and then they give you. So they won't even ask you directly diagnosis. You just need to process that in your brain and come up with associations. And associations are child syndrome, which is congenital hemidysplasia with ichthyosiform erythroderma and limb defects, recessive dystrophic epidermolysis bullosa, lymphedema, GVHD. And I didn't know about this when I was looking about this case. See, this is new for me. It can happen in psoriatic lesions treated with PUVA and in psoriatic lesions of HIV patients. So these two things are new for me. I didn't know about that. Any questions? Good. So what is this city? What city is this? Any guesses? Okay, you don't. This is Milwaukee, and I just it has special place in my heart. This is the place where I disembarked from immigrant boat, so figuratively speaking, and I spent there about 8 years, and I did my dermatology training at Medical College of Wisconsin there. And this is art museum. It's by architect Santiago de Calatrava. And it's a really beautiful place to visit. And this is like seagull wings. So basically this, when the museum closes, the wings retract or they go down. So it's really fun to watch the whole process. So this is, look, older gentleman with a lesion on the neck. Looks like pinkish, yellowish, papule, crusty. So what is your differential? Anyone, anything?
Squamous cell.
Yep. Excellent. Yeah.
Amelanotic melanoma.
Excellent.
Scrophaloderma.
Yep. Great. So we'll see. So a little bit of info. It's 68-year-old white male with lesion on left posterior neck, growing for months. So it's been there for several months. So this is a shave biopsy. and shows like epidermal hyperplasia with clear cells, crusting on the surface, and like protruding into the dermis. It looks like it kind of buds out into the dermis. And the cells, they look like they're a little darker cells. They look a little bit pleomorphic. Any differential at this point or diagnosis? Okay, I'll move on. So again, close up a little bit. So these cells are pleomorphic here, looking different. They have some mitosis, but they look almost like nicely lobulated, almost like there is a little kind of palisading here. But there's also the hyaline mantle, a little bit remnants of it. Close up again, a little bit of hyaline mantle here. You can see it going down here. Mitosis around. Large cells, again, mitosis here, probably mitosis. So what is your differential at this point?
There is verrucous carcinoma and clear cell basal cell carcinoma.
Okay, good, excellent. So obviously it's malignant, whatever it is, it needs to go off his neck,
And porocarcinoma.
Excellent. But when you see hyaline mantle and clear cells, what kind of benign neoplasm comes into your mind? Anyone? So hyaline mantle and
Eccrine tumors or tricholamoma.
yeah, tricholemal verruca, tricholamoma. Yeah, that's a great one. So again, mitosis, pleomorphic cells. So this is tricholemal carcinoma. So it does look like has features of tricholamoma, but it has obviously malignant look. It has mitosis, pleomorphic cells, budding into the dermis. So it shows up on sun-exposed skin of older people. Many consider it to be a clear cell variant of SCC. And treatment is the same as it would be for SCC, just excision. And I had several cases actually since this one on the neck, and just recently I got one on the left lower eyelid on one patient. So it's not that uncommon, but some people just simply call it SCC with clear cell features. Okay, what is this city? Anyone? Any differential for this one? Laszlo? Would you know?
Well, I mean, it is looks familiar, but all these big cities are kind of familiar.
I agree. They all look very familiar, but I spent several years
We had
there.
here a dinner at there is a little Bob, on the right hand
Yeah,
side, and we
yeah,
had a fellowship dinner there.
Wolfgang Puck's restaurant there.
Correct.
So this is Dallas, Texas. I spent a year there during DermPat fellowship at Dr. Cockrell's lab. It was a fun place, and we really enjoyed it and made many friends there. So this is another case here. I think it's the last case. So this patient showed up with some red scaly papules on his umbilicus, around umbilicus, and this kind of belly is also a bit of a giveaway. Any differential?
Scabies.
Yeah, excellent. Yeah, it could be. Yeah, looking like this in picture could be like a little kind of burrow.
Gutted psoriasis.
Yeah, psoriasiform. Yeah, looks like psoriasis. What can you say about his belly? Is it good size? It looks like he has ascites.
Ascites, exactly. The Tupenisharis has ascites.
Yeah, excellent. And he also has this rash on his shins and calves. Looks a little bit purpuric, so we have biopsy also from there. What's your differential here?
Cryoglobulinemia, SCLE.
Excellent. Excellent. So we'll see. So this is a copy from the CPRS and VA system.
Yeah.
It's from the clinician's note.
Dr.
So
Penishero also offered necrolytic erythema.
that's excellent too. You know, patient obviously has ascites, so probably cirrhosis, VA, probably alcoholic, unfortunately. So this is what we get from physicians who request consult. So complaints and findings. Patient with a generalized rash. So this is from general internal medicine physician. So, or resident. Patient with generalized rash, present on abdomen and on bilateral lower extremities. And now with renal failure with concern for vasculitis with skin findings. Please assist with skin biopsy. Attempted treatments and responses on antibiotics for presumed cellulitis. So this is a 55-year-old white male, so a relatively young guy. And this is the biopsy from his abdomen. Shows a slight epidermal thickening. Looks like there's a parakeratosis going on here. A little bit of follicular hyperkeratosis and some dark cells in the superficial dermis, looking like it's around blood vessels. So we'll look close up here. Any differential at this point? I see a bunch of neutrophils here, a little bit of spongiosis, and also extravasation of erythrocytes, and some infiltrate around the blood vessels, but you can't see what kind of infiltrate. It looks like dark cells. Any differential at this point? Okay, I'll move on. This little close-up, I just want to show you that those are indeed neutrophils, a little bit of spongiosis. So when we have a little bit kind of spongiform pustule kind of looking, that's called also spongiform pustule of Kogoj. It's not Kojoj or Kojoj, it's Kogoj. So spongiform pustule of Kogoj. I know because he was chair at University of Zagreb Medical School in Croatia. Chair of the department, so it's Franjo Kogoj who described it. And again, extravasated erythrocytes in the superficial dermis, bunch of neutrophils around. So we see neutrophils, lymphocytes, and extravasated erythrocytes. And this spongiform pustule. So what is your differential at this point? Anyone? Just go ahead, shoot something. So close up again, nice few neutrophils here. So that was one thing, and now it's a different thing. Now this is his shin. Shin showed up follicular hyperkeratosis, some fibrosis, and extravasated erythrocytes around. What's this? Anyone? I'll wait 5 seconds.
Scurvy.
Excellent. So if someone has scurvy, what else he can have or she can have? So obviously he's not eating well. So I could have some other nutritional thing going on too. And this doesn't look like scurvy here, this belly bias. So what else could it be? So probably has scurvy and something else going on. And someone already mentioned in original differential. So now we have a little bit of history. The patient is indeed alcoholic with cirrhosis. So. And his zinc is low, 48. So what is it then?
Necrolytic migratory erythema, acrodermatitis.
Yeah, excellent, excellent. So it's a zinc deficiency and probably vitamin C deficiency. The problem is vitamin C, if anyone eats a little apple, immediately you get it high in your blood, so it's hard to detect. So you need to be very you need to have high suspicion of it. So when one nutritional deficiency is going on, probably there's another one going on too. So just how it should look. So it usually look in acral and periorficial distribution. This is zinc deficiency. It can be pustular, like in our gentleman, bullous and red scaly crusted plaques and diarrhea. It usually acquired in alcoholics and those with increased zinc requirements like metabolic stress, pregnancy, and renal disease. And he had the double hitter. He has the renal disease and he's alcoholic too. And so these are classical pictures in this acral erythema in kids, perioral distribution, looks psoriasiform here. So you always need to think about this nutritional deficiencies and zinc deficiency. This is a picture from some paper that shows that it can be pustular too. This looks closer to what our patient had. And so PAT on zinc deficiency, classically we always kind of read that in our textbooks, is pallor of the upper epidermis. But frequently you don't see that. And you've just seen some non-specific findings or these neutrophils in the corneal layer. It looks almost like some kind of psoriasis. Looks kind of looks like psoriasis, but not really psoriasis. And in late lesions, this pallor is usually absent. And it may look psoriasiform with parakeratosis. So our patient had this parakeratosis with neutrophils or just spongiform pustule of Kogoi, plus minus superficial perivascular infiltrate of lymphocytes and neutrophils with extravasated RBCs. So our patient had this psoriasiform parakeratosis. He had this spongiform pustule of Kogoi, and he did have these neutrophils and extravasated RBCs in perivascular distribution. The interesting thing to point out that patients usually have low alkaline phosphatase. So when you look in blood work, look for this if you suspect zinc deficiency, because this enzyme is zinc dependent. So when there's a low zinc, you may have low alkaline phosphatase. Sometimes zinc, if you look for zinc in the blood, it can be falsely normal level, low normal level, because when they use vacuotainers, zinc can leach from the rubber stopper. So it can leach into the plasma and give you falsely normal or low normal levels of zinc. So you need to look also alkaline phosphatase. So this is one of the classic examples of this zinc deficiency. And almost any nutritional deficiency can look like this pallor and psoriasiform parakeratosis and kind of lack of almost granule cell layer. So this is this classic one that we don't see much often. And this is what my patient had, but this is from this case that I showed you earlier. It's spongiform pustule and some neutrophils in perivascular distribution here. So this is this kind of spongiform pustule of Kogoi. So how to treat this? And actually I had a hard time to find exact treatment. Everyone says, oh, you need to supplement with zinc sulfate, but it was hard to find for how long and what should I do, how much. And so I found in this paper, and that's a journal of the Japan Medical Association, so I had to really look for it. So you need to use zinc sulfate 1 to 2 milligrams per kilo per day. You supplement for 3 to 4 months if initiated within 6 months, or for whole 6 months if initiated later than 6 months. So early cases you give a little bit shorter, longer case you need to give longer. Excessive, you need to be careful because excessive supplementation will lower serum copper levels. For vitamin C supplementation, do 1 gram for 7 days, then 100 milligrams daily. Any questions about the case? Okay, good. Thank you. Anyone, what's this city here? Is this Dallas or Milwaukee? No, this is Kansas City. And I'm living here since 2006. I love it. It's a great place. I miss the ocean, but it's okay. I love it. Any questions?
Well, thank you very much, Vishay. It was a fantastic talk and very, very good cases. We all enjoyed it. So thank you so much for coming on.
Thank you, guys.
And,
Thank you for listening.
Yeah, and it
Take
was.
care.
I mean, I especially enjoyed, because I have been like we are like neighboring nations, so I've always I had a cytologist whose name was Gogoi, and at the University College of London, and I called this, also Gogoi in the pustular lesions. And but it's good to have, from someone authentic to agree with that. So
Yeah, it's a probably maybe it's Hungarian last name. I don't know.
no, it is not. Anyway, Visha, thank you very much, and thank you very much for those of you who joined us. It was an excellent meeting, and see you guys next week. Okay, have a good night, and
Take care.
bye.
Bye.
Learning opportunity.